Welcome everyone, and thank you to those joining us live and those listening afterwards. I'd also like to warmly welcome our guests today, pharmacy heroes who I'll shortly introduce. Next slide, thank you. First of all, I'll be your moderator today. My name is Nai-Hwa, currently a clinical pharmacist working in Xinguang Hospital located in Taipei, Taiwan, and mainly in charge of the internal medicine critical care unit and international rotation coordinator. Also the upcoming 2021 FIP-YPG Steering Committee Chairperson of Public Relations. Next slide. FIP's vision is a world where everyone benefits from access to safe, effective, quality, and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, sciences, and education. The following are just a few important links and resources for you. Next slide. Please note this event will be recorded, live streamed on FIP Facebook profile, and it will be freely available for all. To all those listening, please feel free to send your questions through the Q&A, not the chat box, and we will be picking those up throughout today's session. Next slide. I'm pleased to be delivering this event, a special series of Responding to the Pandemic Together, episode number 33, titled COVID-19 Complex Case Presentations. Next slide. So today we are going to look into the treatment when it comes to COVID-19 and how rapidly it has evolved, leading to novel information about the virus and the safety, efficacy of potential therapies. So some patients may present with mild symptoms. Others become severely ill, requiring extended intensive care unit stays. Through this webinar, we will be presenting 2 COVID-19 patient cases involving complex care. This includes highlights on how to manage uncertainty during the pandemic and multisystem inflammatory syndrome observed in children. I'm now pleased and excited to introduce our panelists for today. First, we have Edurne Fernandez de Gamarra Martínez, sorry if I mispronounced, is a hospital pharmacist specialized in critical care, pediatrics, and pharmacokinetics. She graduated in Universidad Complutense de Madrid and completed her residency program in Hospital de la Sante y Santa, located in Barcelona, Spain, where she works. She is also a board-certified pharmacology specialist and has well experienced in international cooperation projects. She is a resident preceptor at the pharmacy department and also university teacher at Langone. You may have the floor. Thank you.
Thank you very much. I would like to thank the organizers from FIP for inviting me, and also thank you all for being today connected to this webinar from different countries. When I was invited to participate in this webinar, I was asked to present a COVID-19 complex case, but then I realized that what has been really complex for us has been to manage the lack of evidence about the treatments and the uncertainty during the pandemic. Obviously, we have seen very complex patients, and we are still seeing them, especially those in the ICU, but we are not used to not know how to treat a disease, and taking decisions or establishing treatment protocols in this context has been really a challenge. Next slide, please. So first, I'm going to take a look at the context that we were living in March this year. I think this is important to understand and realize how difficult it was to organize the patient care those days when the hospital completely changed in less than 2 weeks. In March 13, the hospital where I work, the ICU, the medical ICU has 15 boxes, and that day 2 of them were with COVID-19 patients. But 2 weeks later, we had 90 COVID ICU patients, not only ward patients, but only in the ICU we had 90. So as you can imagine, the hospital had to create ICU beds wherever it was possible in the operation rooms and everywhere. So it was crazy for everybody. The hospital capacity almost doubled in those days, and most of the patients, almost 90% of the beds were dedicated to COVID-19 patients. And at those days in March and April, which information sources did we have? Obviously, we were reading all the papers that were being published, but we were also sharing information through WhatsApp, seeing the TV news, and sharing information in Twitter. Next slide. Okay, now I will tell you about the case of this woman, 56 years old, 74 kilograms and 160 centimeters, with no relevant medical history, just an appendectomy when she was young. She was a healthcare worker working at a nursing home, and when she was admitted into the emergency room, she was hemodynamically stable, no fever at that time. I will say that symptoms had started like 7 days before, and oxygen saturation was 92%, heart rate 72, respiratory rate 22, and blood pressure 139/72. And in the chest images, we could see bilateral pulmonary infiltrates. So finally, she was diagnosed with respiratory failure due to COVID-19 pneumonia. Next slide. According to our protocol, she was classified with a clinical phenotype 2 as a consequence of the fever, hypoxia, and chest image. And that meant that she was admitted to the hospital, not in the ICU, in the normal, in a COVID ward. And having this protocol really helped us to take decisions about where the patient should go, either going back home, going to the ward, or going to the ICU. And according to the World Health Organization ordinal scale for clinical improvement, it will be a mild disease category 4 or 5. Next slide. So she was started with this treatment that was following our protocol at that time, April 2020, not now. So she was started with oxygen, hydroxychloroquine with a loading dose, and then 200 milligrams BID for 6 days, azithromycin and bemiparin. As you know, hydroxychloroquine and azithromycin were drugs that at that time, in March, April, were proposed that could be used to treat the coronavirus infection, and bemiparin was used to prevent the thromboembolic events. Next slide. And just to elaborate a little bit on our role as pharmacists monitoring the treatment, I will say that it was important to check drug interactions, not in the case of this woman, since she was not taking any other medications, but in some patients, in some other patients that had previous treatment, we had to check the interactions. And as you may also know, both hydroxychloroquine and azithromycin can increase the arrhythmias risk, so it was important to monitor the electrocardiogram at baseline and periodically during the therapy to assess especially the QT prolongation. In this case, the QT was 420, so it was okay, and she could follow with both drugs. And I also want to point out that it was a challenge for us to guarantee an appropriate stock of all these drugs during the peak of the pandemic. Those drugs and also the ICU drugs used for sedation, vasoactive drugs, as if you are working in hospitals, probably you suffer a similar situation. And next slide, please. Okay, so in general, the treatment strategy for COVID-19 patients was to give supportive treatment, especially in the more severe patients. Also giving anticoagulation to prevent the thromboembolic events. Also check and cover other infections that may appear that was especially relevant in intensive care patients with risk of ventilator pneumonia or bloodstream infections, and then consider anti-COVID treatment. And this was the most difficult thing because we are used to know how to treat infections. Obviously, sometimes it is not easy and we have some resistance problems with some patients. But in this case, with this pandemic, we have 100 of patients and we didn't know how to treat this coronavirus infection. So in this context, we decided to prioritize clinical trials, trying to contribute to generate knowledge about the treatment. That is what we need. We need to know which drugs work, in which patients, and how to use them. Next slide, please. So when we talk about anti-COVID treatments, what do we mean? We can summarize that drugs proposed to treat the coronavirus infection were at the beginning chloroquine or hydroxychloroquine with, in combination or not with azithromycin, some antiretrovirals as well, and the famous remdesivir. And as you may know, in some patients, the infection can produce a cytokines storm and high levels of interleukins, especially interleukin 6, that has been observed. And this increase is also related to a worse prognostic of the disease. So inhibiting this pathway of the interleukin with drugs as monoclonal antibodies as tocilizumab or sarilumab or also anakinra has been proposed to treat the coronavirus infection. And then we also have the corticosteroids, as you may know, to help with the inflammatory systemic response. In the next slide, we have a graph where we can see these different drugs and the place where they can work with chloroquine or hydroxychloroquine and ribavirin as antiviral agents, and then tocilizumab inhibiting the interleukin 6. And going back to the case in the next slide, here you see how the patient was admitted on day 9 and after the symptoms started. And at that point, she started with, as I have said before, with hydroxychloroquine, azithromycin, and bemiparin, and then she was considered a candidate for tocilizumab treatment. But as I said, we wanted to prioritize clinical trials, so she was enrolled in this TOCOVID clinical trial and was randomized to the control group. This trial is a multi-center, randomized, and open study designed to assess the use of tocilizumab for coronavirus infection. And main outcomes are mortality, the need of mechanical ventilation in the ICU, or the need of a rescue dose with IV tocilizumab. So on day 12, after the beginning of the symptoms, the patient worsened and had to receive this dose of IV tocilizumab, considered like a rescue dose. Finally, she recovered, so evolution was good, and then she was discharged 4 days after the dose of tocilizumab. At that time, all treatments were finished and only the bemiparin was continued at home. Next slide. Here, to expand a little bit more on this topic, here you have this famous graphic that probably you have seen a lot of times, but I think it's really good to understand the different phases of the disease progression and when the potential therapeutic agents can be used. And probably the key is in this stage 2, the pulmonary phase, where we can do something trying to avoid the pulmonary worsening of the patients. And next slide. And now I would like to turn to what I have explained at the beginning about how difficult it is to take treatment decisions. We don't have the evidence. That has been the real challenge and the more complex things for us during the last months. In the next slide, we can see how we are used to do research and then apply the results from the clinical trials in our daily practice. And with these results, we know which drugs can work and in which patients. But in the context of the pandemic, if you do the click Yeah, thank you, Gonzalo. In the context of this pandemic, we have changed this philosophy, and unproven intervention has been given outside of research. And then, please click. Yeah, and then taking decisions in this situation is what is really, really difficult. In the next slide, we can see how in April, we didn't know almost anything about this drug in this new condition of the coronavirus infection. We knew that remdesivir or hydroxychloroquine could have antiviral effects in vitro, but we didn't know about the safety profile, especially with hydroxychloroquine. We were concerned about cardiac and hepatic adverse reactions. And then we thought that maybe interleukin-6 inhibition could work, as it was working in other effects in immunotherapy-induced cytokine storm in cancer patients, but we didn't know if it was going to work in COVID-19 patients, and we were aware also of the increased risk of infection. So there were many questions to be answered. Please, next slide. And here I would like to share with you this reflection, this topic. When I read it, I really liked it. Here they say, the authors of this paper, that the publication of these results in high impact journals, and also the social media attention and the misguided physician enthusiasm had meant a rapid uptake of unproven interventions. And in this background, the key question is if these drugs provide real benefits to patients, because benefit from the interventions may improve their survival and quality of life, but harm may do the opposite. So what do we need? We need large multi-center randomized trial with high internal and external validity, and we are seeing that now, and also an ethical and a moral imperative. And now we know more things. There are still many questions, and we still don't have a good therapeutic agents to fight against the coronavirus infection, but at least we know which drugs doesn't work as antiretrovirals or hydroxychloroquine. So if we go back to April with the information we now have, we wouldn't treat this treatment in the same way. And we also know what can we do with corticosteroids and remdesivir that are the more promising drugs now. Next slide. Thank you. I want to share with you this interesting and useful tool from the ASHP, where you can find information about the evidence of all these treatments. Just checking in the links. I really recommend that. And next slide, please. Let me point out again this message that something doing less is more. The arguments on social media are based more in emotion than science sometimes. And take in mind that not giving a medication lacking high quality evidence of benefit does not equal just standing there and doing nothing. It is providing them with the best possible chance of surviving without complications. And we always have to have that in mind. And next slide. Thank you. Finally, I would like to have a glance on how can we contribute to generate knowledge. Obviously, the best way is to design randomized clinical trials, but I also would like to share with you this project that has been promoted by the Spanish Society of Hospital Pharmacists and has been developed by hospital pharmacists. I guess most of you will be hospital pharmacy, so I wanted to share this project. Is the Spanish Registry of COVID-19 pharmacotherapy results. A lot of centers, hospitals in Spain were enrolled, and we hope it could give us some light about the evidence of the treatments that has been used during the last months. And we still have the pandemic ahead, so hopefully this information will be useful. And next slide, please, Gonzalo. Yeah, and much research remains to be done and several questions have yet to be answered. So in the meanwhile, difficult decision making will still be present, unfortunately. And in the most difficult weeks in March and April, we really suffer taking these decisions. And these ethical recommendations that are published here help the clinicians a lot to take decisions, and also us to take those decisions related to the treatment in a complex where we had high pressure, scarcity of resources, and these ethically difficult decisions could impact over the patients, the families, and also on the professionals. And in the next slide, we can see how difficult decisions in the pandemic area should be taken. Decisions should be rational, looking at the evidence that we have, and for that we need urgent, good randomized clinical trials. They should be profitable, taking into account how resources distribution is, and also respectful. That is very important, and we have to consider the compassionate use when we are using drugs that are not labeled for that use, and asking for the consent from the patient or the relatives. So the next slide is just my last slide, and my take-home message is that one of the more complex things we have faced during these last months is that taking decisions with no evidence is really difficult and really challenging. I have attempted to give you an overview on how important is to generate knowledge, and finally I leave you with the desire that this second wave that we are suffering in most places, I think it goes better, and I hope we don't suffer difficult days at that one that is represented in this from the New Yorker. So yeah, with this desire I would like to finish, and thank you all for your attention and for being here today. Thank you very much.
Thank you for that wonderful and very detailed presentation. For all those watching, feel free, if you have any questions, as previously mentioned, to just leave it in the Q&A box. And I actually do have one question for Edurne and myself. So you did mention the tocilizumab clinical trial. I was wondering if that is still going on, and what are the criteria when it comes to selecting your patients, and what's the effect when it comes to the medicine so far?
Thank you very much. I'm not sure if I understood all the question. I think it was related to the clinical trial, right?
Yes.
Yeah, we are still running with this clinical trial. There are several centers involved, so we still don't have the results. And almost all the patients requiring oxygen, and not patients in the so patients, adult patients, were candidates for the study. And yeah, we hope to have the results soon, as tocilizumab is one of the drugs that it's been widely used for the coronavirus infection. And the results that we have already published from other clinical trials, they are promising, but they haven't seen still statistically different results, so we will see.
It's kind of like a last option, because I did notice how you did mention the patient was kind of getting worse, and then you guys decided to give her IV form tocilizumab, hopefully to see a recovery in there.
Yeah, this patient at the beginning was randomized to the control group, so she didn't receive the tocilizumab at the beginning, but then when she worsened, they decided to give this IV dose as a rescue dose. So in these clinical trials, patients that are randomized to the control group, then they have the chance of receiving the drug, and is one of the outcomes that is being measured.
Exactly. Is Anasemon, are you ready or just to... I'll kind of just get started with our second speaker. So our second speaker will be Anasemon Aioub. Anasemon is a pediatric critical care pharmacist at NYU Langone Health, located in New York, United States of America. After receiving her Doctor of Pharmacy degree from Rutgers University, she went on to complete her residency training at Atlantic Health System and the University of Kentucky. She is board certified in pediatric pharmacotherapy. And just a side note, if the presentation does go slightly over time, no worries. For those who need to leave, you are welcome to do so, as the session is being recorded, and we will post this onto the FIP page. And thank you to those still with us. We will be addressing the questions raised by the audiences later. So please do not hesitate and leave any questions you may have for both of the panelists. Thank you.
Yeah, I think our second speaker may be having some trouble with the connection. So maybe we can start with any questions for the first speaker via the Q&A tool. And then in the meantime, Anasemon will be able to join the webinar again. So if anyone has any questions that they can type on the Q&A, we can, for the first speaker, Edurne, we can address those first. Thank you. For all participants, please note we do not use the raise hand function during the webinar. So if you can kindly type your question using the Q&A tool, and it will be addressed by the panel. Thank you very much. In the meantime, since we do not have any questions for Edurne so far, and Busy Bright from Nigeria mentioned in the chat tool that her organization has developed clinical guidance for complex COVID patients for Africa. Busy, would you like to take the floor for a few minutes and address this, explain what this tool, and if for the presentation that Edurne just presented and the difficulties and the challenges that Edurne described resonate with the guidance that you produced? I'll open your microphone that you can address the floor.
Yes, thank you. Hello, good morning. Well, it's afternoon here in Nigeria.
Thank you, Busy.
Yes, we did design what we call study protocols for the COVID-19 response in Africa, and it's in 5 parts. We have the pre-exposure prophylaxis. I'm a clinical pharmacist and also a public health pharmacist. I run an organization called Live Well Initiative Nigeria. Within the organization, we have quite a lot of volunteers. We're over 800 in number, healthcare professionals, pharmacists, doctors, nurses, and it's just a mixture of healthcare professionals mainly. So we did design study protocols for COVID-19 response in Africa. And the first thing we did was to put up the hypothesis for testing, by having debates between physicians and pharmacists. And the protocols, like I said, were in 5 parts. We had the pre-exposure prophylaxis, and then we had the post-exposure prophylaxis, and then for the treatment, we had the ambulatory treatment plan for outpatients. We had the inpatient treatment plan, and then we had the intensive or critical care treatment plan. And last but not the least, which is the 5th part, the post-discharge prophylaxis, post-treatment prophylaxis, because the virus is still shed in the bowels for up to 5 weeks after treatment. And so we believe that it's important to put someone who's been treated on post-treatment prophylaxis so that such a person does not infect others through the fecal route. So I would have wanted to share maybe just a little bit of the protocol with us, but that would take a bit of time. I don't know. But if you went to slide share and you typed in my name, you would find the protocol. Let me type that in here. Slide share, we have the protocol there. If you type in slide share and you type in busy bright, you'll find the protocol.
Yeah, maybe you can type it on the chat box. Yeah, exactly.
Yeah, we've gotten to the level now where the Food and Drug authorities are processing our application for clinical trials, and we are likely to go into clinical trials very soon for the prophylaxis. We're doing this in 3 states of Nigeria, in Oyo State with capital in Ibadan, and then Ogun State with capital in Abeokuta, and then Lagos State with capital in Lagos. And we have partners from different countries in the world that are joining us in this. Thank you.
Thank you very much.
Thank you so much for sharing.
Yes,
Thank you.
Back to you.
So we will be.
I did share it with the FIP actually right as far back as April. Thank you.
Thank you. So we will be welcoming our second speaker, Anasemon, as previously mentioned, from New York, United States of America. The floor is yours.
Hi, everyone. My apologies for the delay. I was having some technical difficulties. But I just wanted to thank the organizers for putting this together, and for all of you who've joined from all over the world. I really appreciate this opportunity, and I hope we can all kind of take something away from the presentation. Next slide, please. So we've heard a little bit about kind of how adult patients are presenting and where we are and where we've come from. But we know that COVID-19 has taken a different form in our pediatric patients. And so today I wanted to talk a little bit about multisystem inflammatory syndrome in children, which is what we're seeing more often in pediatric patients who are presenting with severe symptoms of COVID-19. Next slide, please. And so we'll start with our case. We have a 12-year-old previously healthy male presenting with right neck pain and fever. And so this patient was presenting right at the beginning when MIS-C was first being identified. Next slide. And so 5 days prior to this patient's presentation, he was karate chopped by his brother in the neck. So kind of, you'll see that is what instigated all of this. And so that's why there's a bit of a confounded picture for this patient. Next slide. So 4 days prior to arrival, the next day, he developed a fever up to 39.4 degrees Celsius, and his neck was very painful and slightly swollen. The next day, his mother noted a rash that was started on his chest and slowly progressed down to his abdomen, and it was red and papular in nature. And then finally, the day before he was admitted, mother noted bilateral conjunctivitis, his neck pain, and the swelling was getting much worse, to the point that he could only tolerate drinking liquids and pureed food and was not able to eat any solids. And so on physical exam, I've noted some of the prudent findings here. So you can see he had bilateral conjunctivitis. He had the maculopapular rash over his abdomen and chest. He had the right neck swelling and erythema, which was tender to palpation. And so if we think back to symptoms of Kawasaki disease, which we were finding out at that point that there was a lot of overlap between Kawasaki disease and this new presentation of COVID-19, when we think about those symptoms, he has the conjunctivitis, the rash, and the adenopathy, as well as at this point, he had had fever for 5 days. And so he fits like an incomplete Kawasaki disease picture. And so we were at this point concerned for some Kawasaki disease or overlap with the MISC that we were starting to see. So you can see he was febrile to 39.5 still. He was tachycardic with a heart rate of 157 beats per minute. He was tachypnic with a respiratory rate of 28. We did some imaging at that point, and the CT of his neck was significant for a retropharyngeal abscess extending from the level of C2 to C5. And so we were not sure if that abscess was due to the injury that he had underwent from his brother, or if it was due to some other instigating factor that was going on. His chest x-ray at the same time also had an opacity in the lower lobes. And the picture of the chest x-ray was very consistent with what we were seeing in a lot of our other COVID-19 patients, both adult and pediatric alike. Fortunately, there is no evidence of coronary artery dilation on his echo. And you can see here that several of his labs were abnormal, noted in red. And so you can see that his inflammatory markers were extremely elevated. His LDH and his D-dimer was elevated. His procalcitonin was elevated. All things consistent with what we'd been seeing in our COVID-19 patients. And then, of course, his COVID PCR came back positive. Now, the confusing thing about that is, as we'll see, MISC was thought to be a secondary event after initial infection. So next slide, please. This was around the time that the CDC, the Centers for Disease Control here in the United States, put out the official definition of multi-inflammatory syndrome in children. And so you can see here that the symptoms this patient presented with, he had the fever for greater than 24 hours. He did have a PCR that was positive for COVID-19. He did have several organ systems involved as evidenced by his labs and his imaging. And he had very severe evidence of inflammation. And so at this point, we were pretty certain that MISC was his diagnosis. Next slide, please. And so we'll go through some of his hospital course and how we managed the patient. And so in the ER when he first presented, because of his vital signs, we did give him a normal saline bolus twice of 20 mLs per kilo. We started antibiotics because of the elevated procalcitonin and concern for superinfection given the retropharyngeal abscess. And we finally admitted him to the pediatric ICU where further fluid boluses were required for hypotension and where coverage was broadened and clindamycin was added due to concern for toxin production in the patient's presenting case. Next slide, please. And so on his second day of admission, he was taken quickly to the operating room for an incision and drainage to try to clear the area of the forming abscess. Unfortunately, when he came back from the OR, he'd been extubated, but he quickly developed respiratory failure, requiring re-intubation. His chest x-ray at that point was also worsening. We could see worsening aeration and some pleural effusions. On day 3, at this point, we were convinced that although he did have a retropharyngeal abscess and that may have been independent, we were concerned that the MISC was playing a significant role in this patient's presentation and his illness. And so we decided to move forward with giving intravenous immunoglobulin, or IVIG, at 2 grams per kilo. Unfortunately, shortly after the IV infusion was started, he became hypotensive and required epinephrine, a drip, to be started. And so he only received about 15 minutes of the IVIG before it had to be turned off. Next slide. On day 4, he had improved in terms of his blood pressure, and so he was normotensive. And so we decided to try again and give him another dose of IVIG. However, this time we pre-medicated with hydrocortisone to help support his blood pressure. So the IVIG was given, and clindamycin was discontinued at this point due to low concern for toxin production or toxic shock syndrome. On day 5, he was still febrile at that point. So this was 1 day after a full dose of IVIG. However, his epinephrine was weaned, but then later in the evening required to be restarted. So still quite a tenuous picture at this point. And then finally on day 6, due to the lack of improvement after the IVIG, we decided to give anakinra at 200 milligrams subcutaneously Q12. At the same time, we also started a treatment course of remdesivir, which at this point was available only for compassionate use for patients with COVID-19 or for pediatric patients for COVID-19. And so given his weight, he was able to get the full adult dose of remdesivir, 200 milligrams IV times 1. Next slide. And so you can see here on day 7, there was quite a turnaround. He was successfully extubated and was put on high flow nasal cannula. And his epinephrine was weaned significantly that day. So this is now 2 days after IVIG and 1 day after, or 3 days, sorry, after IVIG and 1 day after the anakinra. And we see this very rapid turnaround for the best. Next slide. And so on day 8, his high flow nasal cannula was weaned and the patient was able to go on room air, and the vancomycin was discontinued at this point. And so the only antibiotic he was receiving was the ampicillin sulbactam for the retropharyngeal abscess, as well as the remdesivir for treatment of MISC. Next slide. And so again, he's on room air at this point and his epinephrine was discontinued. And so hemodynamically, he is showing quite some improvement. And then on day 10, although we'd initially planned for a 10-day course of remdesivir, given the severity of presentation that this patient had, because of the rapid improvement that we saw, we were able to discontinue remdesivir after 5 days of therapy. On day 11, we thought we were out of the woods and things were getting better, but unfortunately the patient presented with multiple episodes of agitation and delirium, which is the first time this has happened through the entire hospital admission. And so we initiated a video EEG in order to see what was going on. Was the patient potentially having seizures or some other CNS manifestations of disease? And on day 12, sure enough, the EEG report came back showing subclinical status epilepticus, unfortunately, and so the patient was initiated on antiepileptics. On day 13, he unfortunately continued to have seizures, and so the antiepileptic doses were increased. And on day 14, he completed his course of antibiotics for the retropharyngeal abscess. Day 15, unfortunately, he was still having some seizures, although less, and so his anti-epileptic doses were increased again. And our infectious disease team initiated another workup, which at this point had resulted as negative. And so we were unsure of what the reasons were for this CNS manifestation with seizures. On day 16, luckily he was stable for transfer to the floor. He was doing much better. He'd stopped seizing, and so we found the sweet spot with his anti-epileptic doses. And then finally, the course while he was on the floor was his anakinra was weaned over 10 days, and he was discharged home on the 26th day of hospitalization. And so the reason that we decided to wean the anakinra slowly, we looked in the literature, there wasn't much information about how to go about coming off the anakinra. Should it be discontinued or should it be weaned? And if it should be weaned, how should we wean it? And there were very few reports that showed that if anakinra was discontinued abruptly, there may be rebound inflammation or an inflammatory state that may occur. And so given everything that this patient had already gone through, we decided to wean it slowly over several days. And so a few things that we learned and kind of wanted to highlight with this patient case. This patient's picture was initially very confounded with the concomitant retropharyngeal abscess. And so it was difficult to delineate, was this true pure MISC happening on its own? What symptoms were attributable to the MISC versus what symptoms were attributable to the retropharyngeal abscess? And this is typical, you know, there are very few patients that we see that are textbook, have only one disease state for us to treat. And this just highlights the need to wear our multiple caps and think of all the things that are going on and do our best to identify what pieces of the puzzle are playing that we need to address. Another interesting observation is the seemingly rapid improvement that we saw after the anakinra and the remdesivir were initiated. They were both initiated on the same day, and so it's difficult to say, was it the remdesivir that led to significant improvement, or was it the anakinra that led to significant improvement? And so after this case, we've seen several others, and depending on their respiratory requirements and their inflammatory markers, we have initiated both agents if needed. And so we still don't really know, you know, is it the anakinra or is it the remdesivir that's really leading to improvement? And then finally, what was the cause of this CNS involvement? Was it because of the COVID or was it coincidence? In the literature, we are seeing some reports of headaches as a significant symptom for presentation for patients with COVID-19. And so we're not sure if there are other CNS symptoms that may be involved in these patients' presentation. And so as we continue to see more patients and as, you know, hopefully more research is done and more clinical trials are done, as Edurne had mentioned, we're hoping that we will find more answers to guide therapy for these patients, so that hopefully, you know, with this winter that is coming now, we will be a little bit more prepared to take care of these patients. Thank you.
Thank you. A very, very interesting presentation. And we do have a few questions for our panelists. So without further ado, the first one goes to Anasemon. So our audience would like to know if your patient used heparin.
For VTE prophylaxis?
Yes.
So this patient specifically, we did not use heparin. Our protocol here is we have a chart that discusses risk factors. And so when the patient initially came in, they didn't fit the number of risk factors to qualify for heparin prophylaxis. However, later on in the presentation, as his inflammatory markers continued to rise, we did initiate enoxaparin. And the reason we initiated enoxaparin is because in the adult side, we are seeing a lot of thrombotic events in the COVID-19 patients. It's unclear at this time, based on the patients that we've seen, if the thrombotic risk is the same. Fortunately, we haven't seen many of that in the pediatric population, but given risks versus benefits, we have kind of slowly started, our preferred is just enoxaparin at this hospital.
Mm-hmm. We actually do have another question when it comes to the mechanism of action of anakinra. Yeah. And remdesivir.
Okay.
So what was the thought behind using that?
Sure. So for anakinra, it's an IL-1 antagonist, and so it's targeting your interleukin-1 activity. So there was a lot of discussion about which of the inflammatory mediators we should be targeting. You know, we have our tocilizumab, our IL-6 inhibitor, we have the anakinra for IL-1. Our rheumatology team feels very strongly that a lot of these patients are presenting with symptoms similar to macrophage activation syndrome. And so we know in macrophage activation syndrome, we've seen success with the with the IL-1 antagonism, and so that's why we chose to use anakinra.
Thank you.
In terms of remdesivir, sorry,
I have a question. Oh yeah.
No, go ahead.
Sorry, continue.
Okay.
No, I thought you.
Yeah. Remdesivir is an antiviral agent that was initially targeted actually during the Ebola outbreak. And so a lot of the research here has been looking at remdesivir, which is produced by Gilead, and seeing if remdesivir is translatable, because it has been tested against other SARS infections. And so that was the thought behind maybe it can be used here for COVID-19.
Mm-hmm. And a question from myself, what are the adverse effects when using these medications we should be looking out for?
Yeah, so with remdesivir, what we've seen the most is transaminitis, and so we'll see elevations in their hepatic enzymes. Other than that, we've seen that it's pretty well tolerated, fortunately. With anakinra, the main thing that I've seen is some injection site pain when used subcutaneously. So in the United States, anakinra is actually only approved for subcutaneous use, but we've seen a lot of reports of it being used intravenously internationally. And so there is discussion as to whether or not we should move towards more intravenous use to kind of circumvent the pain that we see with the subcutaneous injections.
Thank you. So Edurne, I have a question for you. It's from Linda. She's a hospital pharmacist in Indonesia. And is there any adverse reaction from tocilizumab injection, especially when it comes to the patient's kidney or liver? They had one patient that was cured from COVID-19, but after a negative swab, but he did unfortunately lose his kidney function and needed continuous renal dialysis, and unfortunately he later on passed away. So is it possible that he had this adverse reaction from the medication or other reasons?
I'm not aware of any renal adverse events. It is also true that there is not a lot of information in patients with clearances lower than 30. And it usually happens with many drugs that they are labeled just with information for good renal clearance. But I haven't heard about any renal effects of the drug. For that, the most important thing is the increased risk of infections, since it is a drug that is acting in the overall immunity. So we should be aware of that, as it happens with many monoclonal antibodies.
Of course. Oh, I like this question. It's, are you guys giving any vitamin C or zinc tablets to the patients? Is it useful?
We have not really. So when the pandemic started, we were doing zinc in combination with hydroxychloroquine. And really the hydroxychloroquine helps the zinc be uptaken by the cells in order to actually be useful and target the infection. Without the hydroxychloroquine or without some kind of transporter to uptake the zinc, we haven't seen that it's been very helpful. And now with recent literature, we've used less hydroxychloroquine than we did at the beginning, just because of lack of evidence to support that it shows a clear benefit. And so because of that, we no longer have that as the transporter for the zinc, and so we're using less zinc as well. And vitamin C, we have not used very much.
Edurne, what about you guys? Have you guys
we haven't used that. I think the evidence is not enough to decide using it.
Yeah.
But let's say if the patient wanted to pay out of pocket by themselves when it comes to vitamins, would that be okay, or is that suggested?
I think it's they are of little harm, and so if the patient wanted to do that of their own accord, I don't think it would cause any harm. But I think it would be important to just make it clear that we really haven't seen benefit with those agents.
Yeah, so thank you. And with these, actually, I would like to say one thing. Oh, sorry. It's what would you like to say? If one thing to the pharmacy workforce around the world, a message during these difficult times, what it would be, one sentence message, please. Thank you.
I think I would say just learn from the experiences of those around you. I know that different areas of the world have kind of been hit at different times and have seen their numbers increase at different times. And I think it's important for us to all work together, because I know when we initially started seeing our numbers rise, you know, a lot of Europe had already experienced that increase in numbers, and fortunately there were publications for us to start to read and kind of to extrapolate and learn from them and see what worked for them and what didn't work for them. And so I think this is a great platform to learn from each other and be able to see what the different experiences are and what the different agents are, what the successes have been and what, you know, the difficulties have been. So I think continue to kind of join these different platforms, and, you know, this is a great way to learn from each other.
Yeah, I agree.
Definitely.
And that's the key, working as a team.
Yeah.
And learning from the others and trying to generate knowledge, because it's what we need to fight against the pandemic.
And with these powerful messages, we will wrap up today's episode. I would like to sincerely thank our panelists and FIP for the unique opportunity. This recording of the episode will be made available on www.fip.org/coronavirus, a webpage that includes all of our COVID-19 resources. And this is an opportunity for me to invite you to also join our Facebook group called COVID-19 and Pharmacy, where you can join a global network of pharmacy, discuss anything related to the pandemic. And we will be providing a 4-question survey that will pop up at the end of the event. So we request that you please give us your feedback so we can continue to improve our digital event offerings. So again, thank you so very much, and good day to you all.
Thank you.
Thank you.
Thank you.
Thank you.